Right. The title of today's presentation is Patient-Focused Strategies to Effectively Diagnose, Treat, and Manage NF1 Plexiform Neurofibromas. My name is Angela Hirbe, and I'm the director of the Adult Neurofibromatosis Clinical Program at Washington University in St. Louis. My disclosures you can see on the slide here. So a quick review of the learning objectives. We're going to go through some of the pathophysiology of NF1 plexiform neurofibromas. We'll talk about the key evidence available and emerging MEK inhibitors for the treatment of both pediatric and adult patients with NF1 plexiform neurofibromas. Talk about some updated strategies to ensure timely diagnosis and monitoring, and then really dive into strategies to choose and optimize MEK inhibitor therapy. So let's dive right into an overview of NF1. So neurofibromatosis type 1 is the most common tumor predisposition syndrome. It occurs in about 1 in 3,000 live births, and it's characterized by a genetic mutation in the NF1 gene. The NF1 gene encodes for neurofibromin, which is a known tumor suppressor and active in almost every tissue in the body. And a lack of functional neurofibromin leads to hyperactive RAS signaling, which is what leads to the tumor formation. So in order to make a diagnosis of neurofibromatosis type 1, a patient has to have at least 2 of the criteria shown in this figure. So 6 or more café au lait macules, which are large birthmarks, neurofibromas, so at least 2 neurofibromas on the skin or 1 plexiform neurofibroma, identification of a pathogenic germline NF1 variant by genetic testing, an optic pathway glioma, a first-degree relative with NF1, a distinct osseous lesion such as sphenoid wing dysplasia or long bone dysplasias, greater than 2 Lisch nodules or choroidal abnormalities within the eye, and then axillary or inguinal skin fold freckling, so areas that don't typically see the sunlight. There are varied clinical manifestations of NF1, and these different manifestations occur at different time points throughout a patient's life. So some of the things that are present at birth tend to be the café au lait macules, some of these bony dysplasias, and plexiform neurofibromas. A bit later in childhood, so between infancy and early childhood, we start to see things like learning deficits that can manifest ADHD or autism spectrum disorder. There can be motor and speech delays, and this is the time period when we start to see optic pathway gliomas pop up. When we get into later childhood and into adolescence, this is when we start seeing skin fold freckling, Lisch nodules, scoliosis, the different types of neurofibromas like dermal and cutaneous neurofibromas start popping up, and then brainstem gliomas. And it's really in adulthood that we worry about the very aggressive high-grade tumors, such as malignant peripheral nerve sheath tumors, which arise from the benign plexiform neurofibromas, breast cancers, and high-grade brain tumors. So we think about how these tumors, plexiform neurofibroma tumors, develop. You have loss of the wild-type NF1 allele in the Schwann cell lineage. So you start with these heterozygous Schwann cell precursors. And when you lose that second copy of NF1, in the context of different environmental cues from these heterozygous cells within the microenvironment, you can end up with a plexiform neurofibroma. And then other genetic changes, such as loss of P53, CDKN2A, or components of the PRC2 complex, lead to development of malignant peripheral nerve sheath tumors, that aggressive cancer. So we think about the natural history of plexiform neurofibromas. We think of them as being congenital, so they're likely present at birth. They may not manifest until early childhood. They really grow most rapidly in children less than 5 years of age. And these are very infiltrative tumors, most frequently located in the trunk or extremities. And they definitely have the potential to cause serious problems. They can obstruct major organs and potentially be life-threatening. But they're also very disfiguring, and they can be very painful. And these morbidities tend to worsen over time without treatment. And additionally, there is about an 8 to 13% lifetime risk of a patient getting an MPNST from one of these tumors transforming. So in terms of working up and screening these patients, any individual with NF1 should be assessed for the presence of a plexiform neurofibroma. And if one is identified, then it's very important to monitor that plexiform neurofibroma over time for growth and also whether or not the patient develops symptoms. And this is done through pretty standard evaluation, so history, physical exam, including a good neurologic exam. And then if needed, MRI would be the imaging modality of choice. This is typically done for those patients that have symptoms suggesting a plexiform neurofibroma, but you can't see something on clinical exam. And it may really inform management in terms of whether or not it's okay to observe, surveillance intervals, and whether or not we need any other additional diagnostic information. And I think many of us believe that having a baseline whole body MRI can be useful in that transition from pediatric to adult care. So we know whether or not there are internal plexiform neurofibromas that need to be monitored. So just to talk a bit about the disease burden with these tumors. So, morbidity is very high for both pediatric and adult patients with NF1 plexiform neurofibromas. I think some of the most common complications include pain, difficulty with motor functioning, motor deficits, weakness. Some tumors, based on their location, can cause issues with vision or bowel and bladder dysfunction. Some of the tumors in the neck, can cause airway obstruction. And we also worry about transformation to malignant peripheral nerve sheath tumors. Again, these have a high rate of metastasis, and the survival is typically less than 5 years. And so in terms of treatment, many patients may end up needing surgeries, and these are associated with varied outcomes. Unfortunately, many of these tumors will grow back despite surgical resection. And there's also a lot of psychosocial issues that can impact the quality of life. Living with debilitating pain is obviously very hard for patients. And then some of these tumors that are disfiguring can make social situations, very difficult for these patients. So if we think about, treatment options for NF1 plexiform neurofibromas, from a surgical standpoint, if you can get complete resection, so get all of the affected tissue out with minimal morbidity, then that is ideal. There are some situations when only a debulking can be done, so just partially removing the tumor. And then there's, situations where surgical resection may not be possible at all without a risk of serious complications. And so there's really been an unmet need for systemic therapies. So we know from prior research that conventional chemotherapy and radiation therapy are really not effective for these tumors. And carry more risk than benefit. But an understanding of the molecular pathways has led to the development of targeted therapies for NF1 plexiform neurofibromas. I think it's very important to note that when we decide on surgery versus medical management, we really need to have multidisciplinary input. So it's important for, a team of surgeons and NF1 experts to really talk about what would be the best treatment for any individual patient. So surgery can be preferred if resection can be achieved without significant morbidity. But again, some caveats, it's only about 15% of cases where we can get complete tumor excision. And we know that there's regrowth when we have these partial or subtotal resections. And there's also the risk of permanent neurologic damage in upwards of 5 to 18% of patients. And so you really need to think about kind of specific contraindications, pre-existing conditions, and really assess logistics, adverse events in terms of deciding, whether or not a medical treatment is going to be good for a patient as well. I also think it's very important, prior to starting therapy, especially in adult patients, where we know there's that risk of malignant transformation to MPNST, to think about that malignancy possibility. So if there's a change in tumor growth rate in an adult patient, or new or recent change in their pain then that's important to work up potentially with other imaging and a biopsy before just jumping to therapy, systemic therapy. So obligatory signaling pathways, so we can talk about these targeted therapies and where they're hitting in the context of these NF1 related tumors. So there are several MEK inhibitors and tyrosine kinase inhibitors that have demonstrated activity against NF1 plexiform neurofibromas. And we'll talk about some of the data related to that. The outcomes of note in the clinical trials have been really tumor response in terms of 3D volumetric analysis, and then patient-reported and functional outcomes. So you can see here, cabozantinib is one of these oral tyrosine kinase inhibitors, and this is hitting very upstream, so extracellular in this signaling cascade. Whereas the MEK inhibitors, such as selumetinib, mirdametinib, and others, are hitting here at MEK, so downstream of where the NF1 gene product functions. The two FDA-approved MEK inhibitors that we have are selumetinib and mirdametinib, and we'll go a bit more into the data on each of these throughout this talk. So selumetinib is a MEK1/2 inhibitor. It's approved for inoperable symptomatic plexiform neurofibromas in children with NF1, and it's still under investigation for use among adults. But there was efficacy in adults demonstrated in the COMET study, and we'll talk about some of that data. Mirdametinib is also a MEK1/2 inhibitor, and this is approved for inoperable symptomatic plexiform neurofibromas in both adults and children greater than 2 years of age. Trametinib, binimetinib, luvometinib are all also MEK1/2 inhibitors that have been studied in phase 2 studies with responses reported, but these do not have FDA approval for this indication at this time. And then cabozantinib is the multi-kinase inhibitor that has also had responses reported in phase 2 studies, but does not yet have FDA approval for this indication. Also important to think about the safety and toxicity profile of any systemic therapies that you're considering. So in children, with these MEK inhibitors, we tend to see more of a mild rash as a common side effect. Paronychia tends to be fairly common. And then nausea or other GI symptoms are really the big things that we see in kids. In adults, it can be a very severe acne-like rash that can occur. Paronychia is less likely, but we do occasionally see in adults. Weight gain, fatigue, and then specifically diarrhea in terms of GI side effects are also fairly common things that we see in adult patients. In terms of monitoring considerations when you're thinking about starting a MEK inhibitor, very important to have a physical exam, including a careful, skin exam at every visit, which is generally monthly. Review of symptoms, specifically asking about skin, vision changes, GI side effects. An ophthalmologic exam should be done at baseline and then every 6 to 12 months. And certainly if there are any new visual symptoms, then they should be seen by ophthalmology. An echocardiogram should be done at baseline and then every 3 to 6 months. There have been decreases in ejection fraction reported in all of the studies with MEK inhibitors. And so that's why it's very important to monitor this throughout therapy. An electrocardiogram or EKG should be done at baseline and then as clinically indicated. Again, pregnancy status, these medications would not be recommended during pregnancy, so important to have a pregnancy test in a woman of childbearing age at baseline, and then per institutional standards. The other kind of laboratory examinations we would do baseline and then every 3 to 6 months include a creatinine kinase. There have been elevations in CK reported in every study. As long as these are asymptomatic, we can tend to watch them. But again, very important to ask about any new muscle pain or weakness. A metabolic panel, including liver function tests and a CBC. For these patients, it's very important to have an NF1 expert sort of leading the therapy for these patients. So I like this Venn diagram because it shows just how many different physicians might be involved in the care of these patients. And again, I think that's even more important to have somebody who's really, driving things for any individual patient. But you certainly may need input from dermatologists, neuropsychology, radiology, genetics, cardiology, ophthalmology, the surgical specialties. And then also, important to point out social work, psychological therapies, and spiritual care, because a lot of these things can be very debilitating and impact patients on that psychosocial level as well. So we're going to go through some cases on how to treat and manage NF1 plexiform neurofibromas. So we'll start with a 30-year-old female patient with NF1 who presented with pretty debilitating back pain that had progressed over the past 18 years. So she was diagnosed with NF1 as a child. That back pain started at age 20, and imaging showed a large plexiform neurofibroma along the spine. She was someone who used to be very active, but had now gotten to the point where she was unable to run races or play volleyball due to pain, which these were things that she very much wanted to do. So we had ordered imaging, and this is what things look like in two different views of the MRI. So you can see this very large plexiform neurofibroma, thoracic, extending into the mediastinum, very widespread throughout the spinal and peripheral nerves. And so, we talked about this patient in tumor board. Complete surgical resection was not feasible and thought to come with a very increased risk of morbidity, even if they were to do a debulking procedure. And so, we talked about systemic therapies. So if we look at the data for selumetinib in adult patients, median duration of treatment was 28 cycles, so quite a long time. Treatment-related adverse events that led to dose reduction or discontinuation were, fairly significant. So 42% needed a dose reduction, but most patients were able to stay on. Patients really experienced decreased tumor pain intensity and pain interference. And the most common side effects are things like the acneiform rash, increased CK, and most of these were grade 1, so able to be tolerated. If we look at tumor response, so in terms of partial or stable, 60, pretty good. Median time to progression was not established. And the best change in tumor volume was down by 24%. So I think it's important to note how long it takes to get a response. So, time to first radiographic response is about 12 months. And the range here is pretty big, 4 to 54. And best response, you're getting close to 2 years for that. So important to, set expectations for patients that they're not going to have a fast response to therapy. The COMET study looked at selumetinib in adults with inoperable plexiform neurofibromas, and this was a placebo-controlled study. So it was selumetinib versus placebo, but patients were allowed to cross over, after they had been on placebo for about 16 cycles. So there was very clinically significant objective response rates. Again, reduction in target plexiform neurofibroma volume. And this was a durable response. So, 86% of patients remained in response for greater than 6 months. So again, if we look at partial tumor response, so 20% in the selumetinib group versus 5% in the placebo group. Best change in tumor volume, a reduction of 34% in the selumetinib group. And this was by cycle 16. Again, also very important to note that there was clinically meaningful reduction in, chronic target plexiform pain intensity score. And, no new safety signals were seen. So if you look at this, certainly a greater reduction in pain in the selumetinib group. There certainly does seem to be some placebo effect here, because even patients in the placebo arm were noting some reductions in pain. Now, if we turn to the ReNeu data, so this is the large phase 2 study with mirdametinib, which is what led to FDA approval in both pediatric and adult patients. The median duration of treatment was 22 months. Again, some patients certainly needed to have dose interrupted. There were dose reductions in, a significant number of patients. And then some did discontinue. Again, the most common treatment-related adverse events in children tended to be, some dermatitis, paronychia, nausea, decreased ejection fraction, and increased CK. In adults, again, this acne-like rash is really the most common thing that we see, along with some diarrhea, nausea, and fatigue. And if we look at the tumor response, so 41% of patients had a partial response in the adult cohort, 45% with stable disease, nobody progressed. Best change in tumor volume was a reduction of 41%. And again, the median time to first response was about 8 months. And so you're not getting a quick change in radiographic response. And those numbers were pretty similar for the children as well. Now, if we look at cabozantinib, this is that multi-kinase inhibitor, and we look at the adult adolescent data, we see a partial response in about 42% of patients. We see stable disease in about 58% of patients. Median plexiform neurofibroma volume change of about 16%. So certainly not as robust as the MEK inhibitors. There were some patients that required dose reductions. And then in terms of the adverse events, diarrhea, nausea, asymptomatic hypothyroidism, and fatigue were pretty common. I think the most disturbing to the patients is the palmar-plantar erythrodysesthesia that can happen, because this can be very painful. So going back to our patient that we talked about, who had the very extensive plexiform neurofibroma in the extending along the mediastinum and the spine, where a surgical resection was not feasible. MEK inhibitor therapy was started for this patient. She did experience some of the common side effects, like the MEK inhibitor rash, which you can see here. Paronychia is pictured here. This patient did not experience this, but this is a fairly common thing that you can see in children. So again, we think about the skin issues that one can have, the GI issues, assessing for musculoskeletal issues because of that elevated CK, and then the general symptoms of fatigue and edema that can happen. So this patient did develop a grade 2 rash within 2 weeks on her chest and back. We ended up starting doxycycline as well as a triamcinolone ointment, and her symptoms did improve. By 10 months on MEK inhibitor therapy, she was running again. She was able to travel abroad. She and her husband were playing sand volleyball again. And ultimately, she decided to stop the MEK inhibitor therapy after 22 months. She had been doing well, so almost 2 years on therapy. And really, her symptoms did not return. So for her, her follow-up imaging after treatment really didn't show a significant decrease in size of the tumor. But she had definitely had an improvement in her symptoms. And I think that brings up an important point to remember in adults, is that reduction in pain doesn't always correlate with a dramatic change in imaging. I think another point that I've learned in caring for these patients over time is that this skin toxicity is pretty significant in adults, and it's almost 100% of patients that are going to have an acne-like rash. So I will tend to pre-medicate to try to avoid those dermatologic adverse events because it can be very painful and, disfiguring for patients to deal with. And again, for a medication where you need to be on for a decent amount of time before you see benefit, it's really important to make sure that you are handling toxicities such that patients can stay on therapy to see that benefit. So we'll move on to another case. So this is a 20-year-old female with NF1 who had presented with left thigh pain, kind of dull, worse with weight bearing. She was diagnosed with NF1 as a child based on cafe au lait macules, axillary freckling, plexiforms, and Lisch nodules. She'd had multiple surgeries for plexiform neurofibroma. And she ultimately was referred to ortho-oncology and mentioned very significant back and leg pain. And so that led to imaging, which showed two concerning lesions. One was this sort of dumbbell lesion along the spine, and the other one was this distinct nodular lesion within a plexiform neurofibroma, in the thigh. So we wanted to further work this up, and this led to PET imaging. And you can see that sort of dumbbell lesion doesn't really have a very high SUV, whereas the lesion in the thigh certainly did. But again, this patient is an adult patient complaining of pain that is new and worse than her typical pain. And so she actually ended up going to the emergency room shortly after that PET scan with very severe back pain and weakness, and ended up being taken to surgery on that admission urgently. And that pathology ended up showing a high-grade MPNST. So, despite having a PET scan where we had a relatively low SUV, that lesion ended up being an MPNST. And a MEK inhibitor would not be suggested therapy for MPNST. And this case really brings up the importance of doing an adequate workup for pain from a presumed plexiform before starting a MEK inhibitor. And again, imaging can be deceptive. So I think another unmet need is, needing improved diagnostics to distinguish these entities. So moving on to another case, this is a 45-year-old female with NF1. So she presented with a painful facial plexiform neurofibroma that was also causing significant deformity. And this patient was diagnosed with an NF1 plexiform neurofibroma as a child. The pain was similar to what it had been for years, so no new or changing pain. And MRI for her showed absolutely no concerning features. So this patient, again, no concerning, features. So we started MEK inhibitor therapy, and at an 18-month scan, there was a 25% reduction in tumor burden that was seen. And the patient continued beyond 2 years, and by 2.5 years had a 57% reduction in tumor burden. And of note, it was pretty early on in the treatment course, so certainly before we saw a radiographic response, that she did have a reduction in pain. And that is an important clinical point, is that those pain improvements tend to be seen earlier, usually within the first couple months, whereas that radiographic change with MEK inhibitor therapy takes a median of about 8 months before you can see a benefit. Next case is a 30-year-old male with an NF1 plexiform neurofibroma who's been seen annually in clinic. So he was diagnosed with NF1 as a child when he presented with cafe au lait macules, Lisch nodules, and skin fold freckling. He was noted to have an orbital plexiform neurofibroma that was first excised at age 14, and then again at age 16, and then again at age 20. MRI, again, no concerning features. So you can see stable plexiform neurofibroma around the eye. And you can see kind of on both of these different MRI images. So for this patient, you know, as we were talking in clinic, everything is stable on the MRI. There is a visible plexiform neurofibroma, and it did cause deformity. But at that point, the patient was asymptomatic, really not bothered by the appearance of the lesion. And so he didn't want to have any further surgery. And he also, you know, wasn't interested in a systemic therapy at that point because the plexiform wasn't bothering him. And this brings up, I think, another important point is that all plexiforms don't warrant treatment. So if it's not bothering a patient and there are no concerning features, you really can just leave it alone and continue to watch. So in conclusion, you know, plexiform neurofibromas will develop in up to 50% of patients with NF1. These are typically congenital lesions, may not manifest until early childhood. You can have asymptomatic and symptomatic plexiform neurofibromas within the same individual. And the growth of plexiforms varies between tumors, both within and across individuals. Unfortunately, the vast majority of patients will have at least one plexiform neurofibroma associated morbidity, and these do tend to worsen over time without treatment. While these are benign tumors, they may progress into a pre-malignant atypical lesion and then undergo transformation to NP&ST. And so that's important to consider when you are following these patients and working up and thinking about starting systemic therapies. Imaging plays a vital role in the management of patients with plexiform neurofibromas. Careful selection of treatment versus observation is important to really maximize benefit and minimize risk. Surgical versus medical management should be evaluated with input from a multidisciplinary team, again, to make sure you're making the right decision for every individual patient. And decisions regarding indications for and scope of surgery really need to be tailored to the tumor's extent, the location, the growth rate, the radiographic features, and the patient's overall health. So at this point, there is a complete, a brief post-test and evaluation form to fill out. When that's done, then you can get your AMA, ABS, or ANCC certificate, and you can go to the Practice Point CME website for further archive presentations of interest and to look for additional accredited continuing education credit. And here is the QR code. So thank you.